May. It's Stroke Awareness Month. And guess what we are talking about once again? Diabetes, heart disease, and stroke. Those things that don't get enough attention. They're kind of silent. They aren't always something you're aware of, but we want to bring your attention to it. We have today a special guest, and this is Robin Scott. Wave your hand, Robin. There you go. Robin is a community leader and advocate. She comes to us with a passion for bringing awareness to stroke prevention. She is a nurse by training, and she is a neuroscience program manager for the Bon Secours Comprehensive Stroke Program. But guess what? She's from Richmond. She's been in Richmond for a long time. She's homegrown too. For those of you who belong to St. Peter Baptist Church, you know, she reached out, and look at that clap of hands. You can go ahead, you can give family love and a shout out. It's a good thing to have those who we care about. But she's been in Richmond since 1984, never left. She went to VCU. I'm not putting dates by there, Robin, for you, but it's already out there and on there. She is qualified and credentialed. She's got a double master's in nursing. She has been a nurse and caring for over 32 years. Now look at that face. She's doing something right, because she does not look like she's been in nursing for 32 years. Come on, y'all, give it up. You know it. You know it. She's been married for 31 years. She's got 2 children, and she said it herself. She has a cherished grandson whose name is it Grayson? Did I get it right? Okay, that's excellent. I don't remember. I think it's Jerry and Elise who are your children, and you've been married to Alvin Scott Jr. for that 31 years.
Yes.
We are so delighted that you wanted to share your passion with us. You have been a part of the neuroscience and stroke program at Bon Secours for years, and it is your delight and pleasure to help people understand in a way what stroke is, how they can prevent it, all the things. So I'm going to stop talking, because y'all know I can keep talking, and I'm going to allow you, Robin, to have the floor. But everybody, please come off mute. If you have a question, interrupt her. Don't let this be a lecture. What do? We have conversations. Don't be ashamed. Put it in the chat. Do whatever it is you can. I'm going to ask Japs, will you share the presentation, or is that okay with you, Robin? Okay, perfect. All right. I'm going to go on mute and ask Robin to come off. Thank you and welcome, Robin.
Thank you. Thank you for welcoming me, everybody. And I do recognize some faces. Been at St. Peter now for probably 10 years. I can't recall, but I used to be at First African Baptist. But needless to say, like you said before, I've been in Richmond since 1984, and I just never left. I really like the Richmond region, and I'm happy to have my St. Peter family and all my other family from the Richmond area. And so today I wanted to bring you information about stroke, just to make you more aware of how it affects the African American population. And I gave this talk recently at the Boo Williams Center in Hampton Roads, because I really think that the African American population needs to understand how stroke affects our race more so than other races. And I bring to you today the statistics. I was saying earlier, if you weren't on the call, that one of my professors would be upset with the way I packed my slides, but I purposefully put all of that information in the slides so that you wouldn't have to take notes and you would have the information, right? And so I put a lot of information in there. I may not say it all, but it'll be there for you. You can go. So I like to start out with the facts for stroke. And I want you to notice the one thing that you don't see on here specifically is how it affects the African American population. So stroke is the 5th leading cause of death, right? And then every 40 seconds, someone in the United States experiences a stroke, which equates to every 4 minutes, someone in the United States dies from a stroke. And stroke kills 2 times more women than breast cancer annually.
Mm,
But what you don't see on here is that stroke is the third leading cause of death in the Black African American population behind heart disease and accidents
mm,
including gunshot wounds and that sort of thing. Next. So I really packed this slide, as you can see. So some of the facts that you can see that African Americans comprise 13.3% of the population, but we have a twofold greater risk for suffering a stroke and experiencing greater post-stroke disability. And we all know how that can, sort of affect the aftermath of a stroke, because then you're talking about rehabilitation and care, and that all requires a lot of money, right? But stroke rates for African Americans in their 30s, 40s, and 50s is higher than whites. And that comes because of mostly because of our diet. So we're seeing younger
mm,
and younger people that are having strokes. And for several reasons. Younger people are more obese. They're not eating, sort of in a healthy way. Younger people are smoking and vaping, something that we talk about a lot when we're out in the population that is just so detrimental to your health. And then a lot of young people don't see a doctor on a regular basis. So there are numerous reasons why you have that higher risk in the 30s, 40s, and 50s. As you get older, you become more aware, right? More cognizant, and you visit the doctor more. And so you're doing things more to impact your health, whereas younger people are not. Uh, and then just wanted to point out here that preventable to observed stroke deaths from 2020 to 2017 was largest for the African American population. And as you can see, the statistics there, 63%. 63% compared to the white population at 20% and the Hispanic population at 19%. That is huge. Those are huge numbers. And so I packed this slide purposefully because I wanted to make an impact with the factual information on the African American population. Next. We more on the risk factors. 90% of all cause strokes in the African American population are a result of the following. And you talked about it earlier. You talked about diabetes. You talked about heart disease, but high blood pressure, overweight and obesity, diabetes. African Americans have a higher, more common genetic disorder such as sickle cell, high cholesterol, smoking, so huge. I cannot emphasize that enough, how smoking just impacts our population so much more. And then not exercising regularly, and then stress. And our stressors are different, and we all know that. We face daily stresses that are completely different than any other race. I have a girlfriend that says, honestly, Black people are the chosen people because we've endured so much and we're still going.
mm,
And she's right, but all of that takes a toll on us, right? We are still subjected to so much more stressors on a daily basis.
mm,
Next. And then I just wanted to point out, I had said earlier that women in stroke, women have a higher risk for stroke for numerous reasons, and it's the way that we're built, of course, has a lot to do with because we can reproduce. And so preeclampsia doubles your risk. Of course, diabetes doubles your risk. And then oral contraceptives. And then that you could equate that to also hormone replacement in older women. So
mm,
oral contraceptives and hormone replacement medications tend to make your blood thicker. And when your blood is thicker and you're not exercising, you're not well hydrated, and you're not take care of yourself, can lead to a blood clot, right? And that travels up to your brain and can cause a stroke. And then atrial fibrillation. And then if you look at the bottom statistic there, Black African American women are at high risk for cardiovascular disease, which equates to a stroke, heart attack, and or stroke, again, being the third leading cause of death. And then the CDC, and I don't know if they're going to put it out after this because we know who's in the White House and they don't like to put out information. But the CDC puts out this map every year, and they put it out for all races, and then they do a comparative a map, and it looks completely the same. Honestly, if you lay all of the maps on top of each other, but as you can see in the southern region of the United States, how much more stroke kills, and this is a map of ages 35 plus by county in the entire United States. And you can see the dark purple. I mean, it just shades all of the southern region of the United States. Two, because the leading crop was tobacco, and so they still have again that habit, that smoking habit. A lot of that is sort of generational. But we're getting a little better in the Virginia region. And I think we're getting that information out there. Believe it or not, Richmond has seven stroke centers, and we're one of the largest regions with the most densely populated stroke facilities. And so be thankful that you can rest assured that any facility that you might go to in Richmond, whether it be Bon Secours, VCU, or HCA, that they're probably stroke certified, because we're all committed to improving the stroke health in the Richmond region. And then I think Virginia as a whole is doing a much better job.
Robin, question. Is
Yes.
it also uh, cardiovascular health? Does it overlap just with this same region? So the
Absolutely.
okay,
Absolutely.
okay.
And when you think of cardiovascular health, most people think of cardiovascular health as just heart. Cardiovascular health is heart and stroke. In fact, the American Heart Association partnered with the National Stroke Association. And so now the American Heart Association is the American Heart Association, American Stroke Association. So they took that over because they knew that it was a greater imperative, and they wanted to bring that awareness more so with in line with heart disease. So when you're thinking of heart disease and cardiovascular disease, just lump stroke in there with those terms.
Do you know if this has changed? I mean, this data is like 5 years ago. Do you
They
know
haven't
if it's
put out
about?
they haven't put out any. That's what I was just saying.
Oh,
So
I'm sorry. I
oh, you
just
just came.
one.
Oh, hi, Juanita. No, no. In fact, I was looking just the other day, and the CDC has not put out, and I don't think that they put it out very often. I don't know if they put it out every 3 to 5 years, but last I looked, they hadn't put out anything newer than this, and I don't know that they will, because now they're pulling back on research and
Yeah.
informing us, of course, because they don't want us to know. I don't think it's going to change though, because I teach a stroke class, monthly with Bon Secours, and I've been doing it for over 7 years or so. And this is probably like the third map that I've actually used, and it hasn't changed much, except for Virginia has gotten better, which I wanted to point that out.
Yeah, I just heard somebody say that stroke and, COVID, they've made some links with
Yes.
that. And so I've just wondered if what's the impact
Yeah.
of,
Oh, I have a little bit of that in there too.
okay,
It's
all right.
definitely impactful. In fact, and it's a great question, because I was just talking about women's health and stroke, and I was talking about the oral contraceptives and the hormone replacement therapy. It
Mhm.
basically, those types of medications make your blood a little thicker. So we call it hypercoagulable, and COVID does the same thing.
Gotcha. Thank
Mhm.
you.
Mhm. So what is a stroke? I'm talking about stroke, but not everybody understands. So I always like to point out what a stroke is. And it is a brain attack, right? It is a cardiovascular disease, but it's a brain attack. We concentrate on two types: ischemic, which is a blockage of blood supply in the brain, and then hemorrhagic, which is a breakage of a blood vessel in the brain. And there are different mechanisms for which you can have a hemorrhagic stroke. A blood vessel could just break, or you could have what's called an aneurysm or an outpouching of a vessel, and then that breaks. And so you have either bleeding into the brain or bleeding around the brain, depending on what type of hemorrhagic stroke you have. The most important thing to know, though, is that most strokes are ischemic strokes. So about 87 to 88% of strokes are ischemic, whereas about 13 to 15% are actually hemorrhagic. However, hemorrhagic strokes are the worst types of strokes and way more complicated and cause way more death. Next. So a lot of people are very familiar with TIAs or transient ischemic attacks. And a lot of people think of it as a mini stroke, oh, I just had a mini stroke. But what's interesting to note is that TIAs are actually a precursor to an actual event. And they're warning signs. So we try to educate people to know that if you've had a TIA, treat it like you've had a stroke. See a doctor. If you're not still having some of the signs and symptoms and you haven't gone to the emergency room, treat it like you might have had a stroke or you think you had a stroke, and see a doctor and make them aware of the signs and symptoms that you had. Because now they need to investigate and understand why you had a TIA. Because if you don't get that treated, then you're 10 times more likely in the next 5 to 7 years to actually have a stroke, which is a major event, right? So never ignore it. Always call 911. Never drive. That's another thing that I teach when I'm out in the community. If you think you had TIA or a stroke, never drive yourself. Always call 911. And that's for many reasons. One, because you can have an accident, right? You could be having a massive event and have an accident. But two, we have medications that we can give, but they are very time sensitive. When you have a stroke, we can give you medications, thrombolytic therapy, either in your vein, or we have interventional procedures that we can do. But the ambulance can prepare you better for those medications and or those treatments. As opposed to you trying to drive yourself to the hospital, because now you're wasting some of that time. And those medications are time sensitive and they act on when you were last known well. So that's an important thing to remember. For example, if I woke up at 9 o'clock in the morning and I recognized that I was having some symptoms, that's not my last known well. It might have been when I went to bed at 8 o'clock. I was just fine when I went to bed at 8 o'clock, but when I woke up at 9, I was having these symptoms. So you need to be able to say to the providers at the emergency department that I was fine when I went to bed at 8 o'clock, but when I woke up this morning, this is how I was. All of those clues help them understand the time of last known well, and then how we can treat you, which medications we can use, or treatment options. Next. So there are several ways to recognize a stroke, and I put the American Heart way on here with FAST, right? A lot of people know FAST, spot a stroke fast, face, arm, speech, and time. But we use BFAST at Bon Secours. And in fact, I know across the Richmond market at VCU, because I partner with many of the coordinators and directors and managers of those departments. We have monthly meetings together. We are all using BFAST. But the American Heart decided to stay with FAST because they felt like for the community, it was short and easy. And again, like I said, most strokes are ischemic, and you will find that most strokes will fall in that FAST acronym. But we use BFAST because one thing we recognize is about 40% of ischemic strokes were getting missed, and they were happening in the back of the brain. And so real quick, just want to give you a quick anatomy lesson. So face, it means a certain part of your brain, right? That's the front part of your brain, believe it or not. And it could also be the side of your brain, your temporal lobes. But arm weakness and speech could mean that the middle part of your lobe, you're having an infarct in the middle part of your lobe. So those are most of the strokes that you see, right? That's 87% of the strokes, and then the time to call 911. But balance and eyes happen in the back of your brain, in your occipital region, in the back of your brain, in your cerebellum, which is your balance region. And so that's why we put B and E on it. So we say be fast. I feel like it's not that much more to say or that much more to learn. And if I were having some dizziness or some unsteady gait, or if I was having some visual difficulties, and we say these things happen suddenly, this is not something that's ongoing, lingers long time. This is not something chronic, but this is a sudden attack. So if I had something suddenly happen to me, or I suddenly lost my balance, or I suddenly became dizzy and it wasn't resolving, I would call 911. But I might imagine that that could be something happening in the back part of my brain. And so we like to use BFAST. But whatever you use, recognize yourself or someone having a stroke and get them the help that they need. Again, T is time, 911. So call for help and don't drive. And this is my favorite slide. This is the one I teach my students. This is what I teach all the new nursing students come on, because this one is so impactful. So I always go down to the third row and I round this 1.9 million up to 2 million, but about 2 million neurons are lost for every minute of delay. So you can't waste time. That's why I say don't try to drive yourself. Right. Call 911. They're going to get, the ambulance is going to get to you quickly, and they're going to get you to the emergency room quickly, and we can get you those medications or those treatment options. But just looking at that, every minute of delay is 3 weeks of your life. That's impactful. So I like to show this slide when I'm teaching the new nursing students coming on, because I need them to understand that they need to act with urgency. Next slide. So here are some of the treatment options that I was talking about. So we have what's called thrombolytic therapies, which is an IV medication, and that just dissolves the clot. But again, look at those short time frames, right? 3 to 4.5 hours of onset. These medications, you have to get them in as soon as possible. And then mechanical thrombectomy. That's actually going into the vessel, like you're doing a cardiac cath. I don't know if you're familiar with that, but you go into a large artery and you snake a series of catheters up to the brain and you pull the clot out of the brain. We do that in our neurointerventional labs. And so that's a treatment option. Those are the only two ways that we can actually impact the stroke, the clot that you're having. And then if it's a hemorrhagic event, of course, a lot of times you'll end up having to go to surgery for evacuation of the blood. And then again, that's a long 21, sometimes 30-day course of treating the patient with a whole series of medications in order to reduce that amount of blood. Because when you're having a hemorrhagic stroke, it's a matter of treating why the vessel broke. Was it blood pressure problems? Was it related to your diabetes? But we're going to treat what the problems are. We're going to evacuate the clot, and we're going to monitor you most of the time, 21 to 30 days or so in the hospital.
Is a TIA treated the same way? Like I'm thinking of TPAs and MNAs and those things that are given in the ER. Is a TIA done? Do you get the same thing, a clot buster?
Not necessarily. So sometimes you can, but you have to continue to have the symptoms. So we do a series of, severity score testing on you. And if you score high enough on the severity scoring, then they will treat you. But most of the time, what you'll find with the TIA, it resolves on its own in about an hour. And that's how we kind of know it was a TIA versus it was an actual, an ischemic event.
You brought up a very important question when you a statement to know your time frame. So if
Yes.
it's something going to bed or whatever, and it made me think of that time frame of the 3 hours to 4.5 hours
Yes.
here.
Mhm.
So you got to know when something's happening to you so you can advocate. And I think of how often people are waiting in an ER that may not be seen, and that's time passing as well.
Yes. Now, one of the things too that we've done with the emergency room, so we have a lot of our BFAST signs up in the emergency room. So if people happen to walk in or happen to drive themselves, again, if you call 911, you're coming in the back door by the ambulance. They've already alerted the hospital that they have a code stroke alert. So the team is literally waiting at the door for the person to come in if you're coming by ambulance. Another reason to call 911. But if you happen to walk in, if you don't know what's going on with you, we have equipped the registrar people with algorithms If a person says, I'm having this problem or this problem, they're going there in their algorithm to say, this might be a stroke. And then they're notifying one of the providers to come and take a look at the patient. So we're trying to build in sort of those protectors when you're coming into the emergency room. But again, the best thing to do is to call 911, because that's when you know you're going to get that treatment. The team, again, is going to be waiting for you at the door. Great question.
Hey, Robin.
Yes.
Hi. So could you point out the fact that exercise could actually lead to a stroke as well?
With respect to hypertension and weight and too much exercise, maybe dissection or something? How would
Yeah, or if someone suddenly starts exercising when they have not been exercising, how that could lead to the possibility of a clot
a clot
or
move?
something like that moving through the system very
Yeah.
rapidly.
Well, and I think you've already said it actually. And so again, when most people have not been exercising before, again, you're hypercoagulable. And so once you start moving around, you could actually elicit a clot that moves up to the brain, and you could actually have what's called a PE, a clot in the lung, and or a clot in the brain, because they're moving in the sort of the same direction. But again, it's more about being sedentary and hypercoagulable.
Thank you.
All right, next slide. So the treatment disparities, and I wanted to point this out because this is so imperative, right? My talk is about the African American imperative, because we need to know how we're not being treated fairly. We need to know how when something is happening in the African American population, we're not being offered the same treatment mechanisms as, say, our white counterparts and or our Hispanic counterparts. So although we have a higher prevalence in cardiovascular risk factors, we're less likely to receive those health promoting interventions compared to our white partners. And as you can see in the 2019 study for a mechanical thrombectomy, and this was going on right at the height, right at the beginning of COVID, and when people were coming into the hospital, the treatment options that were made available to whites were 31.9% compared to 10.3% for African Americans, and then 0.3% for Hispanics. And that was mostly for them because of a language barrier. And so people didn't understand exactly what was going on with the Hispanic population, but with the African American population, it was not a language barrier. And so, what does this mean? It means that the life-saving hyperacute stroke treatments compared to whites just aren't there unless we educate ourselves, unless we advocate for ourselves, and we have the information that we need to advocate for ourselves. And it's always good to have a loved one with you, somebody that can speak about your health. So if you think you're having a stroke, if you think someone is having a stroke, and you know someone that knows about that patient's health, it's best to have them go to the hospital with that patient to be able to speak with the providers and the doctors and so forth, and they can give them the necessary information in order to get to the next treatment step. And then I just put in some of the potential reasons. So when I was looking at some of the research, these are some of the things that stood out to me. But stroke literacy, which is one reason why I make it a point to go around and talk about stroke and about the African American disparities, because I feel like if we educate ourselves, right, if we have that knowledge, then we can speak for ourselves. But then we know that a lot of the African American population, particularly in the South regions, you saw on that map, there's a lot of unemployment and underemployment, which leads to being uninsured and underinsured, right? And then poverty and low social economic status, neighborhood and place of residency. There are a lot of food deserts in a lot of the low social economic areas. So people are not eating as healthy as they should. We know that processed foods are not good for you, but that's what they eat a lot of. You have to eat what you have available to you. And it's more like Maslow's hierarchy of need. You're feeding that need that you have to eat. You're not thinking about what's at the top of the actualized pyramid. And then
Do you think having an Afro-American doctor is better?
I I would say in some instances, but there are not a lot of them that are neurologists. I can tell you that. But if you have an African American primary care provider, as long as you have the knowledge and you're able to speak with them about it, I think it's probably not a bad idea to have one. I wouldn't say that having a white one or a black one is any worse or any better. I think it's more about you having the knowledge about yourself and about your cardiovascular risk, and you're able to speak to it. It just makes it more. It makes it easier for the doctors to communicate with you. So I can't really advocate whether it's black or white, but I can say that I don't know how many there are no black neurologists. I only know of one, Dr. Cletus Aralu, in this area. I don't know of any others. And then there's that African American fear for trust in the healthcare industry too. You know, there are a lot of things that have gone on in the past that rightfully make African Americans fearful when they go to the doctor. But I always say, you know, the thing to alleviate fear is to educate yourself. And then I came up with my own health narrative because I've been teaching this now for a couple of years, but basically participate in policy making. I know that's going to be a little harder now, but you know, if we get out the vote, we know who's out there trying to take our health insurance away versus who wants to help us with our health insurance and our Social Security. So participate in policy making and voting and any public health initiatives that come out. Like this is a great forum. Participating in these health initiatives helps to educate. So I'm telling you, and then you tell somebody else. So see one, teach one, do one. All of that acronym comes out, right? And then any other outreach programs that affect their community, try to participate in those, and then advocate for what's right. Again, promoting health concerns that affect the African American population, and definitely getting out the vote. Collaboration and contributions to research. One of the things that I find it very disheartening is that there's not a lot of research on the African American population with respect to stroke and cardiovascular disease. They've done a lot of studies on white folks. You should see the amount of research that's been done to our white counterparts with respect to cardiovascular disease. So we need to, but one of the reasons that we don't have those contributions is because, again, we're skeptical of the health population, right? Of the health industry. And so we're not participating in some of those research studies. So if we have something that's going on with us, if you educate yourself and decide you want to contribute to research, it's always helpful to advance medicine for our race. And then again, education being the great equalizer. I just feel like you can't get enough of that. And we won't have the education if we don't participate, if we don't contribute and collaborate, and then advocate for ourselves. And then whenever you have a stroke or after having a stroke, it's good to prevent yourself from having a secondary event. It's known that after you have one stroke, you're 10 times more likely to have yet another one. And so participate in your rehab appointments. Always follow up with a neurologist after discharge. A lot of people will leave the hospital. I find that a lot of people will leave the hospital. They kind of get back into their bad habits, and then they don't even get to a neurologist. So we have a neuronavigator that tries to follow people to at least 90 days to be sure that they have made an appointment to see a neurologist and that they are following up with the medication and the regimen that we have prescribed for them while they were in the hospital. And then be able to identify and manage any risk factors. Again, there's so many risk factors out there. Anything that puts you at risk for a heart attack puts you at risk for a stroke because it's all cardiovascular disease. And so take the necessary medications and then make the necessary lifestyle changes. Again, eating sort of lower fat and increasing your exercise. Again, if you haven't exercised in a while, do that under the guise of a provider. Be sure that you're checking in with your doctor to say, hey, I want to begin an exercise regimen. I haven't done it in a while. How should I get started? And what should I do to get started? Again, I can't stress enough, smoking, stop smoking, vaping. If you know of anybody that's smoking, one thing I learned before I went into actually being the neuroscience program manager for Bon Secours, I was the neurointerventional manager, and I was on the other side, right? We were doing the clot busting, we were pulling out the clots in the brain. I was on that side of it, and I didn't really understand sort of the imperative behind it. I just knew that this was a procedure that we did, and we had to do it. So I can see it from both sides. But I can tell you that about 80% of my patients when I was in neurointerventional radiology were there because they smoked. It was amazing. And that stood out to me because my husband worked with Universal Health, the tobacco place, and he would always come home and tell me all the things that was in tobacco because he did those logistic slips and so forth. And he said you wouldn't believe the chemicals and the bug feces, and I mean just the things that he would talk about that was actually in a cigarette. And I was like, oh my God, and people are smoking that and putting that in their system. And we just don't know sometimes what we're doing to ourselves because you don't know what's happening behind the scenes. So again, knowing these things and educating yourself on what is happening is so important. But controlling your blood pressure, controlling your diabetes, drinking moderately, decrease your drinking if you drink heavy. And then, of course, any drug use is never a good thing. And then I just put some did you know facts in here. So did you know research suggests that COVID-19 may increase the risk for stroke? And that's what you were talking about, one. So stroke and heart attack. And again, being hypercoagulable, right? It thickens your blood. And we had so many African American patients that died during the COVID pandemic. It was so disheartening to see. It became depressing almost for me to go to work. And young people, so very young, 19s and 20s and 30s. It was disheartening to see. The percentage of stroke deaths during the pandemic was higher among Black adults, 9.4%. Versus white adults. And I only think of that as because we already have some higher risk anyhow. And so with putting COVID on top of that, just sort of exacerbated that. And then interestingly, the benefits of earning your earning potential didn't actually protect you against having a stroke or a heart attack because it's more about your risk factors and your habits and not the amount of money you have or the riches you have, right? But then research suggests that a focus on young and middle-aged groups is required. And that's another reason why I try to have these forums. And the reason why I went down to the Boo Williams facility was a lot of young people. So I got to talk to a lot of young people, which was really good to do. And then again, education. I keep putting that in there, the great equalizer. I can't stress that enough.
And Robin, related to that first statement about the COVID-19 increasing the risk for stroke and heart attack, I've actually heard some people say they didn't take the vaccine
Yes.
because the vaccine has been linked to increased risk for stroke.
I have found no research to suggest that the vaccines have been linked to.
Okay. Some people have just misconstrued that.
Yes.
Then,
I've not found any of my research to suggest that the vaccine had anything to do with more about the severity of the actual virus itself.
So I have a question, Robin. So is any of this hereditary?
Oh, absolutely. Absolutely. In fact, I gave another talk separate from this, and if I can find that information, that presentation, I'd be more than happy to share that. But we actually went into the genetics of African Americans from the different African nations, Nigeria and Ghana and so forth. And they found definitely some genetic linkage that predisposes African Americans to a lot of a lot of the disease processes that we're actually dealing with today.
So is there a way to break that cycle? Is it the eating healthy and the exercising? Will that break it for the next generation?
It's my opinion, and I didn't go into the research to look at it in that particular way, but I would think that anything that you can do to lessen your risk, right? To lessen your risk factors would definitely keep you out of that higher range of people that could possibly have a heart attack or a stroke. So doing everything you can do to lessen your risk for heart attack or stroke. And we have, again, high prevalence of diabetes, high prevalence of obesity. And you would, it's interesting to note that it's the American foods that we've been exposed to, how it affects our systems differently than it affects our white counterparts. So this, in their DNA and in their structure, they were actually acclimated to this. But we came from, when you think about it, we came from another country, brought over here, and then put into their system, right? Acclimated to their food choices. It didn't affect our DNA the same.
Thank you.
Robin, we
Robin,
have
there are
a,
two. Oh, go
sorry.
ahead. I think you're
No.
going to do the same thing, Japs. 2 questions in the chat. Go
Yes,
ahead.
we have a question. We have two questions on chat.
Okay.
We have once a blood clot reaches the brain and cuts off blood flow, approximately how long does it take for stroke symptoms to appear?
That's a great question. So that's a hard question to answer because everybody is built a little bit differently. So we have what's called collateral circulation. So our brain, God made us very unique. Our brain, our blood supply is all connected, right? It's called the circle of Willis. And that circle sits in the center of our brain and it perfuses the entire brain, right? And so if you have a blockage in one area, there's another area of the brain that's going to try to come over and compensate. However, everybody's collateral circulation, right, and their connections aren't built the same. So if I'm a person that, and this may help you too, Tilly, if I'm a person that exercises daily, I'm going to have probably very good collateral circulation because my body is dilating more. My vessels are dilating more. I have great movement around my vessels. My vessels are slick and not stiff. And so my collaterals may be a little bit different than somebody who's more sedentary. Does that make sense? And so you can't really put a number on it. And that's one reason why that whole 3 to 4.5 hour onset is there. It's only a positive number, but that's about where we find that it's safe enough to give some of those treatments before we cause any detriment or harm. There's taking an aspirin daily. Well, you got to be careful because that could be twofold. So taking an aspirin daily under the prescription of a provider, right? You need to talk to a physician before you just decide you want to take an aspirin daily. But you have to be really careful with taking an aspirin daily because if your blood gets too thin, you get too much aspirin in your system, then what can you do? You can cause a hemorrhagic stroke. You could bleed in your head. So you got to be real careful about if your doctor has not prescribed that for you, if they haven't seen any necessary reason for you to do that, then I wouldn't do that. But if you have some heart disease or you have some other issues that require you to take an aspirin, then I would do that. I wouldn't just arbitrarily take an aspirin every day.
Yeah, and you also deal with bleeding of the stomach if you take aspirin.
Absolutely. You could bleed just about anywhere. You're right.
Correct.
Mm-hmm.
Correct.
Mm-hmm.
Yeah.
Hi, Robin.
Yes.
Does TIs necessarily lead to dementia?
It could, because you're causing scarring. So every time you have, they call it an event. Every time you have an event in your brain, you're having dead tissue. That's ischemia is essentially dead tissue. So yes. So it can lead to strokes themselves, TIAs themselves can lead to dementia because those are events. Those are scars on the brain.
Thank you.
And the other part of the question was, are your classes at Bon Secours open to anybody, the public, or are they for those who are being treated at Bon Secours?
No, so the classes that I teach are only for new hire nurses. So,
Okay.
so as nurses are hired into the Bon Secours system across the Richmond market, I teach a class monthly so that they are able to take care of the patients that are coming into the hospital.
Well, we may need to have a course that you teach for the public, the lay public. We need to talk about that. Okay, we're gonna have a discussion later. All right.
Yes, absolutely.
Everybody on this call, just raise your hand and be in support of that so that we can do that with Robin. Okay, that's all
Absolutely.
we need to do. Okay. There, that's great.
All right, Lisa. I would like, this is Evelyn again. we would like to have her come to our senior ministry
Yeah,
and talk to our seniors.
absolutely. Absolutely.
There
You
you
just
go.
let me know. If my schedule is open, I'm more than happy to come.
Okay.
And Robin, I have to ask this. I keep thinking about the question asked about whether or not you should have a Black lawyer. And I want to ask this the right way, as to not
Oh,
be
Black doctor.
Doctor, Black
a
doctor.
Black doctor, to not be accusatory. But do you think, even with COVID,
Mhm.
that Black people were treated by their doctors as they treated their white patients? And and be careful. Like I say, I'm careful. I'm trying to be careful with the way I ask this. But
Right.
the reason I ask it is I know some instances where Black people had COVID
Mhm.
and they passed,
Mhm.
and the white doctors did not put the cause of death as COVID. So
COVID.
they were not counted in the
In the
statistics
numbers.
of the COVID deaths.
I wouldn't be surprised at that. I wouldn't be surprised if that was actually happening, because I have seen on the other side, again, where treatment options weren't given to Black patients at the same rate. And when I was on the neurointerventional side, I witnessed that myself. In fact, I had to advocate. We had prisoners that came in that needed interventional procedures. And the doctors were very reluctant to take them to the interventional lab. And I would have to question, well, why wouldn't you take them to the interventional lab? Well, they're in prison. Well, what does that have to do with them having an interventional procedure because they're in prison? That has nothing to do with anything.
Exactly.
So you could definitely find a case, I'm sure, for that.
Cases.
Mhm.
And not
Cases.
only that, as you know, during COVID, if you passed from COVID,
Mhm.
there
Right.
was government money for
Uh-huh.
Right.
people. And I do know two Blacks that the doctor did not put down the cause of COVID, because that would get them $9,000 toward
Yes,
their funeral
absolutely.
expenses.
Mhm.
And so, kind of relates to Lambert's question about who should you have,
Yeah.
looking out for your health interests as
Mhm.
you do other interests. And I say that
Exactly.
because we know even in real estate, there's been discrimination forever.
Ever.
And I can tell you it is still alive and well. So
Absolutely.
then we need to be careful
Mhm.
of who you use for just about everything.
Absolutely. I agree. I definitely agree.
And we need to encourage more Black youths to go into neurology.
That's right. That's what I was just getting ready to say. And if we could encourage more Black people to go into medicine, and specifically neurology, when I'm talking to the nursing students, a lot of times I'm trying to get them to work in the neuro field and then go on to be nurse practitioners. I mean, I started. The reason that I went to get my master's, I started going in to be a nurse practitioner, and I felt like, you know what, that's just going to pigeonhole me a little bit. I'd rather do something more where I can impact globally a program.
Mm-hmm. Yeah, it takes it all.
Mhm.
It's a multifaceted solution. It's not a
Absolutely.
one. We
Mm.
have to do it. And Robin, you said it clearly
Mhm.
here.
Mhm.
Learn it,
Mhm.
share it,
Share it.
invite somebody back for it, send them
Yes.
to the website, continue to do that.
Mhm.
I don't want to stop you. We're not done. We
Okay.
just go. But what I did want to do is make sure we are equipped with certain questions
Mhm.
that we feel we have the answers to,
Mhm.
or that we can take to our physicians based on the information that you gave us today.
Mhm.
I think that's important. That's something, team, that as we have these sessions, I think I want to incorporate,
Mhm.
that we can leave here asking ourselves these questions. And if
Yes.
we don't know it,
Mhm.
go to our physicians and ask them to provide us with certain answers.
That's right.
So you keep going, Robin, and then I'll come back with these questions. And if I don't get to these questions tonight, Japs will send them out to everybody who's on the mailing list so that you have them, and we'll put them in the replay.
Yep. I think I'm done.
Okay.
Oh, I did put in some resources, so you can go to the American Heart Association. They do have some information, as you can see there, Black Americans and Stroke. Um, it, they really did partner with the National Stroke Association to see if they couldn't bring some more awareness around stroke, not just for the African American population, but for everybody. In fact, we're doing a whole lot more with respect to bilingual information and education that we're giving to the patients. In fact, we have education and information in so many languages now because we have so many different ethnicities being admitted to the hospital with stroke. And honestly, stroke and cardiovascular disease is new to the Hispanic population. They just don't understand it at all.
Mm. Yeah.
Robin, I just have one. Oh, good question just popped up. One
Mhm.
question. I just want to verify this because strokes run in my family, and
Mhm.
I think what I have been told in my research tells me of all the preventive things that you can do. I mean, you can exercise and you can do a lot, but
Mhm.
for the African Americans, it seems like the diet is that one thing. I guess one of the big things that really not helping with the stroke statistics. You can exercise, but if you go get that double
Yeah.
cheeseburger and a milkshake,
Mhm.
you kind of wiped out what you were doing with the exercise. Do you agree with that?
I agree with that wholeheartedly. Listen, I can tell you that it's my opinion. It's my opinion that at the height of the Industrial Revolution, when they brought in high fructose corn syrup and things of that nature, sweeteners that they put into different foods, when they started changing the meat product by putting the additives in it. They call it pink meat, but they started changing what an actual hamburger is. Because when you get those hamburgers that you get at those fast food restaurants aren't real hamburgers. They have so many different products in it. In fact, I did a talk with a cardiovascular doctor in Hampton Roads, Dr. Nash. I don't know if you're familiar with him, but he did a talk the same day that I was doing a talk about stroke. And he really went into some of the things that were in the foods that were creating unhealthy African Americans, right? So the things that really were detrimental to our health. I wish I had his talk, but he went on to say that you won't get the vaccine, but you'll eat one of those hamburgers from a fast food restaurant, and it's probably worse than what anything that would be in a vaccine. And the last thing I want to say about the vaccine is that a Black person actually is the one that stumbled on the actual vaccine. Her Kizmika, can't think of her last name, but she went to the University of North Carolina. But she was on that team, and they were working on a recombinant virus. They were recombinant virus for cancer, and they pivoted. And she realized that you could actually use the protein matter that they were working on for this recombinant vaccine to actually create the COVID vaccine. And so they gave her all the accolades for that. I cannot think of her last name. Kizmika was her first name, but um, it was interesting to note that. And a lot of people think that, a lot of Black people think that the COVID vaccine was invented by some white man to, kill the Black race, when it was actually a Black researcher that actually discovered the COVID vaccine, the original COVID vaccine. Of course, there have been, iterations since then, but the original one.
I think I just Googled that because Kismika Corbett.
Corbin, that's her name. That's her name, from the University of North Carolina.
Yes, yes.
And they were actually working on cancer research. She's the one that uncovered the actual protein that you could use in the recombinant virus to make a vaccine for COVID, which is ingenious. And they're doing more of that now. So now that she discovered that, now they're using that technique to now look at more treatments in cancer realm and other medications. So I think it's so fascinating.
Thank you, Robin. That's excellent. Thank you for the questions. I'm going to reach out for what we said, education,
Okay.
and then we won't forget the seniors. Evelyn will follow up with you there.
Mhm.
Also, Dr. Nash,
Yes.
when we talk about wellness, that would be a good topic about food, health, and wellness to
Yes.
see if I can get his contact from you.
Yeah,
That would be,
he's a cardiac doctor in the Hampton Roads region. I'll look to see if I can find, I did a talk with him a couple of times.
okay. If you can find it, that's not. If not, I'll go looking for him, and Japs and I will try to find him.
Okay.
So I'm going to ask a couple of these questions, and you all can raise your hands or not raise your hands and see if you know the answers to these. If you look at your lab results, do you know by looking at your lab results if you have an indication for risk for cardiovascular disease or stroke? If you see when you go, if you know, we've gone through labs, folks, so people should have some information. If not, it's the question to ask your physician, what of my lab results are indicators that I might be at risk for stroke or cardiovascular disease? That's a number one question. All right. Number two, do you know if your cholesterol and your blood pressure are within a healthy range and what they ideally should be?
Yes.
Okay, Evelyn said yes. If you do, that's great. If you don't, that's another good question to ask your physician and have a conversation about, to make sure that you know, to be educated and to be in the know. And Mary's saying, look at my chart, because my chart will tell you if it's what those ranges are, but do you understand those ranges?
That's right.
Do you understand what they mean? That's what we're aiming for. And here is one that, do you understand when the physician says you're overweight and what those risk factors are? Because Mary, when you said you exercise and you go out and have a milkshake and a hamburger, it should be okay because you burned off those calories, but it's what was in those calories and what you consumed versus having greens and fruit and some other things and different combinations of things. So those are just a couple of things. Say
I was going to say, it's what you put in your system.
Yes. So those are just a couple of things that, if you think of other questions you want to ask or want to know, let's talk about those. But tonight, this has been excellent. We thank you, Robin, for being a part of the conversation tonight. If there are other questions, I don't want to hinder that. And people, time is up. You're free to go. Robin, if you have to go, say good night. But we thank you.
You're welcome.
If there are other questions. So thank you very much.
Yep. And share the information. You guys have it. You can share.
We will send it out when we send out the follow-up, and it will be posted on the website. So you know how to now reach out to the AAHRI site, and you can just go .org and you will be able to see it there. Within 48 to 72 hours, everything is posted and sent out. Questions? Thank you for joining.
Thank you, everybody. I appreciate you.
Appreciate you. Thank you very much.
Thank you.
Thank you.
Okay.
Lisa, I just had one comment in that unlikely case you have to go to the emergency room. As you're getting into the ambulance, I think two things to remember to carry: your insurance card and your smartphone. Because what I have found the time that I've gone into the emergency room, when they do that lab work, you'll get it back within hours. And by the time the doctor comes back to talk to you, you'll have good questions to ask him because you've already accessed your results.
I like it.
I don't know, some people may make the blood pressure a little higher, but for me, I want to know.
That's great. And you want to know. I think that's awesome. Everybody is different. And we have enough information out there now to be as informed as we want to be.
That's correct.
And Robin's point of whether black or white if you are informed and you have the ability to know how to communicate,
Mhm.
you know when communicating if someone is listening to you or hearing you and
Yes.
able to interact with you.
That's
And
right.
if they are not, you can make that clear decision
Yes.
to go
Based on your
someplace
knowledge.
else and solicit additional information. That's what these opportunities about. That's what reading something a bit from Black Health Matters is. That's what Everyday Health is about. It's giving you a safe platform to learn information that is not bad for you.
That's right.
It's safe information.
Mhm.
And that's what this is all about.
It's all about
safe.
being informed.
Yep.
Mhm.
Okay. Mary, I got my insurance card and I got my my phone. Okay. I'm here. If anybody else has a question, go ahead.
I'm
Okay.
out. I gotta